Well, thanks for being here. My name is Alex Huffman. I'm an associate professor of chemistry at the University of Denver. This is Dr. Krystal Pollitt. She is at Yale University, so we will be moderating this first session. It's taken a lot of preparation to get here, and it's a great pleasure of mine to see so many of you here. These panels were organized by Dr. Shanna Ratnesar-Shumate, Justin Taylor, and I, and they're sitting down here, and they're both going to be moderating the second of the two panels that we have for tonight. The symposium that this is a part of is called Aerosol Science of Infectious Diseases, What We've Learned and Still Need to Know About Transmission, Prevention, and the One Health Concept. And as a part of that, we have two panels that you are here for. The first of those two panels will focus primarily on lessons learned from the COVID pandemic, and the second of the two panels will focus primarily on remaining gaps in the aerosol science identified during the COVID pandemic. I'll note that the questions and the focus may be largely on SARS-CoV-2 and COVID, but the questions and answers don't need to be restrained to those boxes, and they may flow outside of that to other infectious diseases. There were many, many great individuals that we could have invited tonight. From this great community. And we are really excited to have the four panelists here in panel one and then the next four in panel two. I'll let the second set be introduced later, but just very briefly, panel one will be Dr. Jennie Cox of NIOSH, the National Institute for Occupational Safety and Health, which is an institute within the US CDC. Dr. Katherine Ratliff at the US Environmental Protection Agency, the US EPA. Dr. Joshua Santarpia at the University of Nebraska Medical Center, and Dr. C.Y. Wu behind me from the University of Florida. I want to make a quick disclaimer for the panelists that the statements presented by panelists represent personal opinions and not official statements or policy from the government agencies or institutions that the panelists represent. The format's going to be simple. There are no prepared talks, no slides other than the one that you see in front of you. The moderators will ask questions. The panelists will have time to discuss. The point of the set of panels really is to just provide an opportunity to have discussions that sometimes fall between the spaces between the technical sessions that we talked about earlier. And we will ask the panelists to try to keep their answers reasonably brief, to try to let the other panelists speak as well, and to get through more content, but obviously we don't want to stifle the discussion. Panel one will last for about 55 minutes. We'll take a very short break to switch into the next panel and then go to the second hour. We are going to be recording the video and audio up here to hopefully share that later. If you're connected on social media, please feel free to live tweet tonight or share comments from whatever platform you are using. If you do that, don't forget to use the hashtags AAAR 2022 and also more specifically AAAR 2022 ID for infectious disease, and those are on the screen as well. Also, so we have prepared some questions to ask, and the moderators will then ask those. We also have the opportunity for you as an audience to ask some questions as well. We're not going to do it via the mic. It's important for you to send those questions in to us via Slido. So the information is right in the middle. You can go to slido.com or sil.do. If you go there, there is just a set of numbers you put in, 1714273. So that's going to be on the screen the whole time. So if you think of a question, go to slido.com, put in that number, type in the question. We will see it, whether in panel one or panel two, and then we will choose some from there to ask questions. So go ahead and do that whenever you like.
All right, thanks, Alex. So as you said, I'm Krystal Pollitt from the Yale School of Public Health. So we're going to start off with the first question. So for each of you, we'll take some turns. In about a minute or so, what was the key thing you personally learned about infectious disease transmission through the COVID-19 pandemic? We can start with CY on the side if you like.
Sure, I can do that. I think the most important lesson I learned is science evolves and expected the unexpected. And I'll just use one example. I think in the beginning, we all focused on healthcare centers, facilities, and we went there to do sampling. And then what's next? There were a lot of concern about, how about the fitness centers, the restaurants, all these things. But we realized later on that actually homes, because of the poor in ventilation, that's actually the one with the highest concentration and the highest probability of getting the virus aerosol. So it evolves over time, and so I think it's important to expect what you did not expect.
Yeah, maybe I'll follow up with something a similar sentiment. But for me, I think the thing that most surprised me was the high degree of variability between person to person. I think going into this, I felt very, very much like people that there was going to be some aggregate or some I don't know, common metric for how people, what we would find in the hospitals with hospitalized patients, and really we see just a high degree of variability between person to person. And it makes the messaging difficult, and the answer's complex, and it means that studies don't always agree exactly with one another. And I think, that's probably the other thing I learned, is that trying to communicate complex science in the public is a lot more difficult than maybe some of us have given it credit for.
That's a good segue to what I was going to end with too.
We didn't plan it.
In my research, I spend a lot of time thinking about new technologies that can help us reduce the risk of disease transmission in indoor environments, and thinking about all these new technologies. Something that's often forgotten is what strong tools we do have in our toolbox to help reduce the risk of disease transmission already. And a lot of these things are very simple, like filtration, if you were able to attend the wonderful talk this morning, source control, wearing masks. These things are simple but not easy to implement, right? So again, it comes back to the communication of what we know, and being able to conduct research in science and move science forward in a way that's easily, communicated, digested, and translatable to action is the most important thing I've seen come out of all this.
Yeah, I have to second their sentiments. With the high variability of different studies, like he was intimating, with all the different varying results, it's really hard to get a clear and concise message. And just as on a technology kind of side, and how we're going to looking into different technologies and how implementing those and how we can judge those to be safe or not safe. I'm looking forward to seeing how it progresses, and hopefully we can all stay on track and not be lost in the weeds of the public opinion kind of sentiments. So.
Okay, thanks for answering those. Okay, so we have one more question, another question, and after this, feel free to also go back and forth if you have any responses to each other. What commonly held understanding do you worry we might not actually know enough about to be so certain? Does that question make sense? Sometimes we get really confident about things, even in this room, and you think, well, I'm not sure I think I'm quite so certain we all believe that as much as what data do we still need to convince ourselves about something, that, whether it be in this community or somebody else's community, that we really need to convince ourselves about?
I'll start this one. I'm not that I'm worried that we've missed evidence so far, but like we do have a common method or common approach to virus infectivity and culturing, and that's the standard and the gold standard we go by. And I think that thinking outside of the box and trying to figure out different mechanisms and ways that we can advance that science, and I think having COVID definitely brought infectious disease to the forefront of our population now, and so maybe with the high demand needed, then maybe that science will be able to progress further.
I don't know if this is exactly the question you asked, but it's something that I wrestle with on all the time, and it's really like how infectiousness works with people that are sick with anything, right? But COVID's been the example that we've all used for so long, and I think there's this maybe commonly held opinion among lots of people that someone who's sick with COVID looks like Pigpen from Peanuts cartoon and just runs around with a cloud of death surrounding them. And it really it doesn't work that way. And I think the data all points to the fact that it doesn't work that way. And so, but I still think we've had trouble maybe kind of coming around to the fact that there is this variability, like I talked about in the first question, that we're not adequately appreciating. We don't adequately understand why there's that variability and what that means for, for transmission.
I want to talk about it from a different angle. I think there needs to be some standard in terms of sampling and analysis. When you talk about PM 2.5, we know what to do. But when you talk about collecting and analyzing, virus aerosol particles, if you check the literature, there are so many different samplers, and even after you collect the samples, how do you extract the materials and how do you analyze them? There is no standard, and that causes confusion because when you compare different data from different studies, can you really compare them? And if you cannot compare, how do we really extract the information when you try to compile all the data from different studies? Can you make any conclusion from that? So standard I think is needed.
Yeah, I'll take that a step further into thinking about, evaluating mitigation strategies. A lot of these are done, and I've seen a lot of wonderful talks here. They're done oftentimes in very controlled laboratory settings. And so having a better understanding of how these lab studies can be extrapolated to real world conditions where there is such a high degree of variability in indoor environments and other types of environments as well, that's really critical for being able to really wrap our heads around how to, again, compare these different technologies and mitigation strategies.
So our next question is about super spreaders. And what do we know why some individuals are super spreaders, and what data do we need to be able to predict and prevent super spreader events? Anyone?
I'll take a wag at this one too. And again, I feel like I'm answering I'm using the same thought process to answer a bunch of similar questions. But I do in fact feel pretty strongly that I think most of us probably have the potential to all be super spreaders and to cause super spreading events. And I think it depends a whole lot on your infection, about what you do, about how these things are caused. I'm sure there's data out there, but the data that I've seen on trying to analyze who's a super spreader and who's not isn't really, it's not really convincing to me that there's some specific factor. And so it kind of leads me to believe, and the variability that we've seen kind of leads me to believe that maybe it's all timing and activity and everything else, and maybe not so much the person or some specific thing about some person's physiology.
I do recall some study that evaluated, people's emissions, and I think about 20% of the people in the study, and I wish I could remember who the study was by, but about 20% emitted a larger proportion of particles than the other 80% did. And the mechanisms behind that are still really unclear, whether it is like physiology, whether they just tend to speak louder or project larger. Those are all issues that are still really not fully pinned down. There is how they breathe, and the lung fluid and how that gets projected is all theorized as well. But I don't, like he was saying, I don't think it's plannable or predictable necessarily either. So.
Okay. Well, thank you for that. For those, some of these we don't have good answers for. Some of them we maybe do. But, and really that leads in a way into this next question, because I was going to consider phrasing that last question as, who would you want to work with to help answer that question? And so the next question that we have is, multidisciplinary work is a necessity when investigating disease transmission and risk mitigation. In the processes of this pandemic, what did you learn about a discipline different from your primary field of study? And you might consider this not only in relation to this, but just considering there's also lots of early career people here as well. And think about that in terms of you as a scientist continually growing. And so, yeah, what did you learn from a field outside of your own?
I can start with this one. My research is inherently incredibly multidisciplinary. I couldn't get away from it if I tried. I work with microbiologists, aerosol scientists, engineers, communications folks, and now a lot of time spent talking to lawyers. So I am within the Office of Research and Development at EPA, but I work very closely with our regulatory partners who are tasked with regulating a lot of the technologies that you might be thinking about in terms of mitigating disease transmission. And so through all of that, I've spent a lot of time, again, talking to not only lawyers, but a lot of our regulatory folks and trying to get my head around what the laws are, what can be done, what all of that means. And that's really important, even though it's not something that I thought I was going to be signing myself up to do. But we can develop all of these neat technologies and strategies, but also need to understand how they can legally be implemented within the correct regulatory framework.
Yeah, definitely. It's very, very important to do multidisciplinary work for solving this problem. And I personally benefited a lot from working with so many colleagues with very, very different training from what I have. Like, I'm lucky to work with John Lindsley. He's a virologist, and he can culture the virus very well. And I learned a lot from him. And also, talking to medical healthcare professionals. And a lot of time in the beginning, it's like, is this English? Do I understand this? Not really, but after several communication, I think both sides understand better each other, and that helps to move the advanced knowledge. Otherwise, like in the beginning, droplet mode, airborne mode, what exactly is that? It's very different definition, even though they are all English, but you needed to work with others.
Yeah, I think, everybody in this room is a multidisciplinary scientist. I don't think you can do any component of aerosol science all by yourself with no collaborators. I think those days are long past. I think, kind of following what CY said, for me, like my experience working with the healthcare community, particularly the doctors and the nurses providing care and doing, it's a much different perspective, right? We can do a lot of science and we can understand a lot of details about how, about aerosols and droplets and what's more important. But if you can't put it into the proper perspective for healthcare, for the practice of healthcare, you can't really make the situation better. And so I think that, one of the biggest things I learned was, how to take into account what they need, their users, like what the user needed to know in order to move forward and to do their job more safely and provide better care, and how to focus my studies around answering their questions, which were really the more pertinent ones, at least for me in my situation.
Yeah, I definitely concur with the sentiment of perspective. Like that during COVID, working on multidisciplinary teams, you definitely get the engineers have a specific perspective of how they want to solve a problem. But then the microbiologists might have, different issues that they need to address with the flow and the engineers. And so everybody really has to work together. And I think without collaborators that work well together, then the science can't advance as easily as it should. Yeah.
So with all these collaborations, there's been a lot of different control technologies that have come up. Some like germicidal UV to do it yourself, box fans that have gone from niche to incredibly popular. What do you think we still need to learn about them as aerosol scientists, and what data do you think we still need to acquire for regulatory purposes or for wider use?
Well, I can start there. I think there's a lot of really exciting technologies on the market that have been used historically successfully, and emerging technologies as well. My concern, and this is me speaking in a personal capacity, is that there's a big challenge with the regulatory framework right now. So a lot of these technologies are technically considered devices, pesticide devices, and so under EPA's regulation of them, they don't go through any sort of pre-market registration or review of their safety or efficacy. And they're regulated, though, in that false and misleading claims can't be made about them. But going back to what we talked about standards, there's no standard test method for evaluating these different technologies. So it's really hard to understand what a false or misleading claim would be. So my hope for the future is that twofold. One, we can come up with standards for evaluating these different types of technologies, whether it's through ASHRAE or other organizations or from the federal government or other organizations, or and again, just we have to have a baseline for comparison. And then also I think we need to think about how the regulatory framework can support not only the end user but also industry. So if there's things that are coming to market that don't perform as expected, that poses a detriment to the entire industry. So, I think the current regulatory framework doesn't really support the consumer or industry, and I hope that there will be change in the future for that.
Yeah, I guess I'll second that in a major way. There was a lot of snake oil sold in the beginning of this pandemic with novel control technologies, and I think a lot of people got burned pretty significantly by them, big buildings and other industries and things like that. And that there's going to be a backlash from that in terms of adopting new and functional technologies. So proving function is going to be really critical. There's a couple of things that I want to add, with regard to the impact of like layered effects of control technologies. Bill Lindsley presented a great talk earlier today about layered effects, and I really appreciate that. It's one of the things that I think we've all tried to message throughout the pandemic. It's not just nothing that we do is perfect, so let's do more and make it all better, generally speaking. But the other one today that I saw was from Jose Luis's group, looking at the secondary effects of germicidal technology, like UV germicidal technology. And I really think these are important things. It's not just about efficacy, but sometimes it's also about the other secondary effects of the technology. And so it's nice to see all that big picture being considered now, and then how we put that into a framework for regulation. That's now your job, right? So I don't. We get to do the science part, but you guys get to figure out what that means.
That's why I'm in the Office of Research and Development and collaborate with the regulatory.
Science policy and regulation.
All right, so building on that, we have a lot of questions coming in through Slido, so thank you for submitting those. And a lot of the questions are asking about what technological advances do we need to better understand infectious aerosol?
Infectious virus aerosol, right? Okay. So I think, I happened to talk to Jennifer earlier, right before this.
Yep.
Yeah, right now, you collect the samples and you have to culture it. It's a very, it's a lot of effort, and it requires high skills. And you also need to have the special facility. You cannot do it at just regular laboratory. You have to do it at a BSL-3. How many BSL-3s do we have over there? So there got to be something. I don't have an answer right now, but I think we need to develop a new method that doesn't really require the current type of culturing, and you can get the answer very quickly. But it's not just detection of RNA, but has to be related to infectivity. It doesn't. I don't think it exists yet.
No, yeah, I was going to agree. I don't think it exists yet, but I do think that technology is rapidly advancing. There's just in the past 10 years, just think how far we've come in like metabolomics and different epigenetic studies and different protein identifications of genomes. So I think the technology will exist soon. How we can identify, hopefully, if a cell is or not. Well, not a virus isn't a cell, but if a virus is alive or not. Additionally, I went to a talk yesterday. The individual was looking at. I think it was bacteria or fungus, but it wasn't virus, but it was using microwave and lasers to determine, if it was viable or not. So I think if we can start thinking of alternatives, maybe other than culturing, that is so labor intensive and specialized, then we'd be better off.
Yeah, I can't help but third that comment. Like it's really like the dependence of us understanding infectiousness based on our ability to culture a virus collected from the environment and all of the caveats and issues and problems that go along with trying to do that process, even if you have the best, technical hands in the world, sometimes those attempts fail. Good protocols and everything don't always address all the issues with environmental samples. And so I think having a better way to identify, like, yes, this is potentially infectious, and like a general understanding of, of respiratory viruses or, all kinds of infectious disease, and how we, best characterize their risk.
All right. So you're warmed up, right? All right.
Hit us.
Now that you've stretched out a little bit, we're going to go big for a second. This is one of the questions that's been upvoted on Slido more. And you can answer from your perspective as aerosol scientist. It took a year for SARS-CoV-2 to be accepted as aerosol spread. Why do you feel that is? And what can we do scientifically to make sure that will never happen again? And just to let everybody else know, the panel did not know that was coming, so they may need a couple of seconds to digest that.
Well, okay, I'll just. I think the weakness that I went back to in the very first comment about communication, right? I honestly don't think we failed to communicate this effectively in the beginning. I don't. I think many of us were very clear. I think there were a lot of barriers to making those communications clear, right? There were a lot of widely held beliefs that were likely, not likely, they were absolutely incorrect, and those widely held beliefs were held by people who, controlled policy and controlled messaging, public health messaging. So how do we fix that? I think we need to have better connective tissue between bench level science and policy. And I think some of the bureaucracy that stands between the people who are doing the real work and the people who are messaging policy decisions needs to disappear, right? Some of that connective tissue needs to grow, and we need to build trust between those communities. It's not a scientific answer, but it is like an interpersonal relationship problem that we need to fix as both communities.
I agree, but at the same time, I also have a different view. I think it's the definition of the terms. Like I mentioned earlier, if it's a droplet or is it aerosol, 10-micron droplet is a droplet or aerosol, and that was very confusing in the beginning, and that was because of the definition and the usage in different fields. And therefore, I think it's very important to have a communication between different disciplines more often to understand what we are talking about to each other. And then we can have a clear message to the public and to policymakers too. And I think Linsey has done a great job in explaining that.
Yeah, I definitely have to second that. When COVID started and there was a debate about terminology, I didn't even understand that there was a debate, because I had just finished my PhD in an aerosol lab, aerosol work, and so I just assumed everybody knew aerosols were aerosols, and there wasn't a big differentiation between maybe what the medical community might have perceived or different agencies might have perceived. So that was surprising to me to find. In addition, I think I forget what the beginning of the statement was, but it's I think it's all a process that has to are right with the communication and the other thing I was going to mention, that's what I remember what it was. I think initially also scientists wanted to say it was similar to SARS-CoV-1, and I think that was traditionally transmitted with close contact and surfaces. So I think scientists in the beginning were hoping it was closer to SARS-CoV-1 and we could use the same mitigation strategies, but we were kind of off the mark on that.
Well, I'll just add that I see the same sort of terminology issues playing out in other ways. So, for example, for the word disinfection has a very specific regulatory meaning for EPA, and so when disinfection is used colloquially, it can be interpreted in very different ways by different people. So I hope, the COVID pandemic gives us a framework or can provide some sort of motivation to overcome some of these communication barriers, because it's not just the droplet and aerosol issue.
And if I may just add one more thing, just my personal story. When I started working on a flu aerosol about 8 years ago, and they told me that to generate aerosol, I said, this is aerosol. And they said, it has to be less than 5 micron. I said, why? And I think, I just, at that time, I just followed their convention and said, okay, I will do that. But at this point, actually, I think if I had the opportunity again, and I will speak out more loudly, there is something wrong about the definition. 8 years ago, not after the pandemic.
Speaking from the AAAR community of aerosol scientists, you've talked a lot about, all of you have talked about the importance of multidisciplinary research and communication and all these kind of things within this type of research. Do you have a good idea of what would you suggest? How do we overcome some of the barriers that keep us from that multidisciplinary connectivity, whether it be on a research level or even communicating to the public level? Do you have ideas that you wish that we would follow through, or even on a granular level from the people sitting in this room? Like, it may be that the very top level people in this room have connections with the White House and wherever, but do you have an idea what the rest of the body in the room can do to try to stoke those multidisciplinary conversations? Like, what is it that we should be doing, do you think? Any specific ideas or hopes or dreams that you have for us?
Well, I guess I'll say that, having things like this panel is a great start towards getting folks together who are interested maybe in a topic, but coming at it from different angles, and just not being afraid to go talk to somebody from a different discipline and somebody from a different agency, and not being afraid to engage with the people who are making the regulations. So I think just it all comes back to communication in the end, and trying to open up those avenues for the ways that we can work together. The best way to do that is by being together and communicating.
Yeah, I mean, it's funny. I think this community is probably the least, might be some of the least guilty of not being multidisciplinary. I mean, I say that comically, because even if you'd asked me like 10 or 15 years ago, like, do bioaerosols have a role in climate, I wouldn't have thought about that in a serious way, but it's true, they do, right? I mean, and that's, it's, bioaerosols are about infectious disease, because that's, where my narrow little brain was focused, but as it turns out, they're important to lots and lots of things, and I think it's, in this community is where we come and, hopefully more than once a year, but for sure at least once a year, and watch some talks in other disciplines that might be somewhat tangentially related to what we do, and this is how we sort of grow as a community. So I think we do it pretty good. Maybe other places don't do it as well, but I don't know, because I don't go to their conferences.
Maybe we should.
Maybe we should.
So let's pull it back down again. We talked big picture, and there's been some specific questions like dream technologies we talked about before, and someone's been asking about real-time detection. Do you think that's possible? What are your thoughts?
Define real time.
Could we go to real-time detection of SARS-CoV-2 or some other infectious aerosol?
Sure. I mean, there's posters. Actually, I saw some posters today looking at real-time detection of SARS-CoV-2. I mean, I think there's all kinds of potential, right, for future detection technologies, and we can start by, putting together the technologies we have and moving towards, like holy grails, like single particle detection of individual species and things like that, which, I don't think is technologically possible right now, but maybe we should be thinking about.
I would like to add, and it's a little off the note, but like as we get rapid developing technologies and more science and more experimental methods and devices, I think that just leads to our lack of a standard as well, because like everybody keeps trying to find a better way to do things. So it's kind of a double-edged sword I think we're facing, is you want to find a better way to do something, but then you also want to standardize it so everybody's finding the same thing. So I would like that solution to come about. But
Yeah, we have to, I mean, every new technology should
Right,
be able to be
exactly.
compared against a
Yep.
standard, right? To see
Yep.
if it meets or exceeds that standard. So, yeah,
But,
we
yeah.
don't have the standard,
Right,
so
exactly,
it's
right.
hard to get there.
Yeah.
If I may, I wanted to, deviate from this topic a little bit. I wanted to say literature review is very important. There actually are a lot of there is a lot of information, or say the technology, or these processes already available, but we are not really, doing a good job in knowing what is already available, and we actually spent in the past 2.5 years a lot of resources doing the same thing. I have to say that, yeah. So, for example, I saw a proposal, 2 years ago. Hey, I wanted to use UV to inactivate, the virus. Yes, that can be done, but we already know that. So, what is new are you bringing? Right? That's a proposal. So that means that in a short period of time, we wanted to rush out, and we don't really do our homework. And then in that case, it's a waste of the resources that can be used better in other places.
This is one of the questions on related to the question on Slido. If you were given a magic wand right now, let's say you're a program manager with no oversight, what would you fund in the short run and in the long run to help us to avoid the problems we've seen and to just improve public health overall, or understand infectious disease transmission, or whatever? What would you fund in the short run and the long run? Or you could answer either.
I'm going to be really boring, but in the short run, standards. Got to have standards to have the long-term, dreams in place, or have a place.
Yeah, I also I would want infectious, like long term. I'd want easy infectious identifying capabilities, so that we don't have to culture. So it's the same answer I've given already, though.
Can I go back actually to both of those before we get too far out of it? Which, especially for the people in the room that are not infectious disease scientists, can you be more specific about standards? Like, what do you mean? What standards of what? Yeah, just be more specific.
Sure. So I think there's two types of standards that we've discussed as a panel. So there's standards for sampling and culturing and detection. There's also standards for mitigation technologies. So, I just see a common theme of throughout the community and all the things that we're working on. Standardization is really critical to be able to move all of these things forward. We can't move forward without a basis for comparison. We don't even know if we're moving forward without a basis for comparison. So that's really critical.
Yeah, maybe like one step before standards for me is improving the understanding of like what we need to have standards for. And I know this is maybe like, I don't know if I'm like splitting hairs, but like I think about this and it's like we think about control technology standards, and I think like standards for effectiveness are great, but we also have to have standards for, secondary effects, right? It doesn't mean that there are zero secondary effects. We accept side effects in lots of situations, but we need to understand what they are, and we need to have limits, right? Same thing on the sampling side, right? It's like, yes, like we need to have standards for sampling, but I need to know what my target is, right? Like, you infect a cell culture with a virus, and people will still tell you that, well, that's not really an infectious virus because it's not a person or an animal or some other thing. And it's like, well, really, like, it's replicating in cells. So, like, what's the argument about it? So, I think there's some details that need to be, and some of this is terminology, but some of it is also like real, like what's the translation space there? And so I think in the short term, we need some research to kind of put put pins in some of those things so that we can build standards so that we can improve the technology.
All right, so building on this wish list with standards, so how can we apply that to the next, if we had to then redo over pandemic response? How could we apply that, build on that? How would it differ from what we did? Would your response have differed and how you responded?
I think if we had standards, we wouldn't have had the issues we had. I mean, just being fair, right? If we had acceptable standards for what constituted, an infectious respirable virus, we wouldn't be arguing about whether or not it was or was not, right? Somebody would have done the work with early patients, hopefully, and we would have had these things accepted like really early on. I would also hope that we could accept some common sense thought process about what constitutes a respiratory virus by something else. So, or how to protect in the worst case scenario until you have better information. That's not science. That's just policy.
Yeah, I think a lot of work still needs to be done with public policy and public trust and perceptions. There's still a lot of false information and people believing false information out there. So I think it's our duty to spread the right information as much as possible and to encourage thoughtful science.
I think another critical or need that would greatly benefit us from a preparedness standpoint moving forward is a better understanding of what appropriate surrogate microorganisms might be. So as we've talked about, BSL-3 work is expensive and hard to do. So if we have a Rolodex of potential surrogates that we have good information about in terms of their, sampling, disinfection, resistance, all those types of characteristics, hopefully we can be better positioned to roll out research more quickly and broadly to labs that may not be able to work in a BSL-3 type of environment, but do that more widely.
And also, once you have the standard method, let's say for the simpler, right? And you don't have to worry about is this the right one, or you can actually spend the energy and time to figure out how you are going to deploy it, how you are going to process the data without worrying, well, this data may not be trusted, or I think that will save a lot of efforts, and we can concentrate on what we needed to do.
So going a slightly different direction with some of this to a more practical side of this, we as a community have done a lot of communication with scientists and the public and media and all this kind of stuff. If you had a bunch of business leaders and school district leaders sitting in the room right now that were wanting to hear some kind of advice from you, what would you tell them about how best to keep their constituents, their children, their whoever, as safe as possible from the transmission of infectious disease? It's like, speaking to that population, what would you say?
I would say layered protection is important to help you save money and get kids in an environment they can continue to learn well. You don't have to lock them in your home and using Zoom that a lot of them don't really like, or even some of them really like so much they don't want to do anything else.
Mm-hmm.
So we have to talk about the cost.
Mm-hmm.
Yeah, I think I would say too that there's a lot of things out there like filtration, source control that we know work, has been used for a long time, and is relatively safe. There's not a lot in the way of secondary chemistry. We take that back. We saw today there can be some secondary chemistry, but compared to other types of technologies, things that we know are relatively safe and effective are things that can be widely implemented without giving anybody too much heartburn. And a lot of these technologies that sound maybe too good to be true, I guess I would caution folks to say, show me the data, show me the studies that are the basis for you making these statements, because oftentimes the manufacturers have a hard time producing those kinds of things. And unfortunately, there's a big discrepancy between sometimes the way things are marketed and the way things perform in the real world. So, speaking in a personal capacity there, I would just caution folks to reflect on the tried and true methods.
I think, a lot of times it does come down to cost and logistical concerns when it comes to implementing even like layered protections. And I think sometimes the phrase "perfect is the enemy of good" is really appropriate here. And I think you have to give people, I think we have to give people guidelines that they are capable of meeting, and at least understand that, like, yeah, if you can get all the way to X, maybe you don't need to have universal masking in this in this conference room. But if you can't get all the way to X, wear a mask for the next hour while you're in that meeting, right? It's not we got to be a little more. We have to make sure we're being reasonable when we communicate like guidelines to people who have to deal with it every day and who have to pay the electricity bills at the end of the day on whatever they're implementing.
Yeah, I do. If you ask a school to implement higher ventilation or box fans in every room, that's a huge energy consumption that they're having to put out on top of maintaining the fans and maintaining everything. Masking is always the easiest, but that's the most hated, so it's not going to fly. So I think it is a really challenging discussion that public communication people have to deal with. And us.
I mean, there's complications with masking too, right? I mean,
right. They're not.
It's
perfect.
not perfect, and getting 4 to 6 year olds sometimes to keep them on and be effective with them. It's just not it's not realistic. So.
No.
Well, thank you for that. So we're going to backtrack to all your discussion about standards, because that's gotten a lot of attention on Slido and a lot of upvoting with some specific questions here. So there was a question on asking who is responsible for setting these standards that you think are so important, and then how can we as AAAR or individuals contribute?
I'm not really sure how method standards are usually I think everybody just jumps on, like if a new method comes out that's really well validated, then everybody kind of historically has jumped on that, like said, yep, that's what we're going to use. I think that the problem is now that there hasn't been that clear leader for aerosol sampling. Maybe I'm wrong.
I mean, standards have to be government accepted, or have some sort of acceptance, which is why I kind of gave you guys the slow look.
Well,
but but to be fair, I mean, this is the community that could develop a standard that could be implemented in this,
I was just talking
choice,
about
right?
methods in general, just like what sampler to pick, what method, what media to use,
Yeah, I mean, as a community, we could develop these standards and we could propose them forward, right? I mean, ASHRAE is another organization that does these sorts of things. AAAR is not an organization that currently does these sorts of things, but it doesn't mean that we cannot contribute to developing something that we feel as a community is a best practice. So that's both parts of the question.
Well, I think maybe this is the answer, but I'm not going to guarantee that. National Institute of Standards and Technology, NIST, they are supposed to develop standards.
Well, so that's taking it from a pesticide product and device standpoint. So from a more mitigation control strategies, EPA again is the primary regulator of pesticide devices and products under the Federal Insecticide, Fungicide, and Rodenticide Act, and so there are chemical pesticide products that are being proposed for use for treating indoor spaces, both occupied and unoccupied, and it does come down to EPA to approve the methods that were used to test those products. There's currently, based on the way that devices, which are the bulk of the things that you would be thinking about, UV, bipolar ionization, photocatalytic devices, those kinds of things, those are not regulated in a way that would require them to be tested under a current, an accepted standard. So EPA is not currently, working on a standard for those, but we are working on, I'm working closely with our regulatory colleagues on a potential set of minimum testing criteria looking towards a standard for chemical air treatments, and hopefully that sort of framework for a test could be applied to different types of devices. And it's something that we're working with ASHRAE on. There are, from a technology development standpoint, there are some standards being developed within ASHRAE for those types of technologies. It's just a slow-moving process.
All right, we got just a couple more questions before we're done with our panel, but these might be fairly quick. Maybe not. A lot of us do not have facilities that can handle live virus. Are there recommendations on surrogates that are available in non-specialized labs to help people do their research?
I mean, there's lots of phage in the world. I think bacteriophage are probably, does it require some containment? Sure, it does, but bacteriophage are probably a good place to start. There's not very many enveloped phage, but there is one, and it's pretty well accepted, pretty common, so it's a good place to start. And there's, I think, a lot you can do with surrogates like that. And the other part of that answer is it depends, right? There's a lot of work on that it's related to transmission in spaces that does not require the use of any kind of live organism, and so it's about the question being asked, and I think there's lots of questions that can be answered without the use of viruses.
So let's build on that and also think back to this multidisciplinary perspective that you talked about so early on. Are there any disciplines that haven't been represented that you think would be useful to bring into better understanding infectious disease transmission, and we can evolve them in the future?
I think probably all discipline can contribute. For example, the transmission is not just a physical, chemical process. It's a human society process. How human behaves definitely affect the transmission. And therefore, like a sociologist, psychologist, they probably can do a lot more in this aspect.
Yes, a sociologist, psychologist also can help get the message out and be much more clear with the science probably than we can, since we know science is ever-changing and continuously evolving, but the public has trouble sometimes grasping that concept, and I think the social sciences are much better suited for that.
Or even political science.
Yeah,
Yeah, that's what I was going to say. Is we need to get the people who are making those top regulatory decisions involved in the conversation as well.
Okay, so for the last question, this will be a little bit more open for each of you, whoever wants to answer it. What's an important topic or aspect of this whole discussion about infectious disease transmission that you just don't think is getting enough attention or discussion? As we put you on the spot.
Could ask that one earlier, Alex.
I know. Can't think.
I think I get bonus points to stump the entire panel.
I think a lot can be done or needs to be done to take that bench scale work to pilot scale to full field scale type of research and demonstration. So focusing on, and it all comes back to the same sort of thing. A standard is supposed to be representative of how something's deployed in the real world, but we know it's not going to be, right? It's still something that's going to be tested in a lab environment. So not only do we need standards, but we also need to know how things that are tested against a particular standard can be expected to be perform in different settings as well. So it's a multifaceted, multi-layered, complicated problem, but we need to, again, just have that understanding of the lab to field.
That definitely is true, and I just wanted to talk about this from a different angle. I think if I were to do it again, maybe I would talk more to, say, religious leaders, political leaders, if I can, and then help them understand the what we are facing and our suggestion, and not me doing the messaging, but they doing the messaging. But if they understand this better, hopefully it will be better for this, for also business, yeah. So hopefully they will come up with better message to the society.
I'm going to kind of follow that thread a little bit. I think, we do a real great job talking to people who listen to us.
Yeah.
We don't do a great job talking to people who don't want to listen to us at all. And you find those people in all the different disciplines, right? In medicine, in business, in politics, and whatever. And we get all of our positive feedback from talking to people who want to listen, and all of the negative feedback from talking to people who don't want to listen to us. And I think we need to get better, maybe by working with the sociologists and the psychologists about more effectively communicating to the people who are reticent. Because if we had been able to do that, I'm not saying that they would have been receptive, but if I would have felt more confident that I was doing something to more effectively communicate to those people, I might have felt better about them not listening to me, right?
Yeah.
I don't know.
Absolutely.
Going once, going twice. All right. Okay, so with that, we are going to take a short break. I want to thank all 4 of our panelists. They did an excellent job answering questions on the fly. So let's give them a round of applause.
right, everybody, we're going to go ahead and get started with the second panel.
We picked that one just for you.
I'm Justin Taylor, and this is Shanna Ratnesar-Shumate, and we both work at Nobles, but spend most of our time providing subject matter expertise to the Department of Homeland Security. On our panel, we have Dr. William Lindsley from the CDC and NIOSH. We have Dr. Lindsey Marr from Virginia Tech, the Department of Civil and Environmental Engineering, Dr. Don Milton from the University of Maryland School of Public Health, and Dr. Jonathan Reid from the University of Bristol. As in the last session, please feel free to get on slido.com and submit your questions, and we'll do the best to triage them and ask them. And I will turn it over to Shanna for the intro.
Okay, so the second panel today is to focus on what we still don't know about aerosol transmission of infectious diseases. And before we get started, I just wanted to kind of give a few facts for everybody in the audience. Since the beginning of 2022, we have had the emergence of a number of very dangerous pathogens globally. We've seen Marburg hemorrhagic fever show up in Ghana. We're nearing 70,000 cases of monkeypox virus globally. Avian influenza has spread throughout the United States, and we've seen zoonotic transmission to humans within the United States. We continue to see the emergence of SARS-CoV-2 variants that continue to spread, and case numbers continue. Flu season is upon us. African swine fever is knocking on the U.S. borders. And now we are looking at 60-some cases of Ebola virus, Sudan and Uganda, with 29 fatalities, including a clinical healthcare worker. A number of these viruses are not spread through aerosol transmission, but they can be contagious and infectious through the aerosol route despite that. And so my first question for all of you is, what is the one thing that you think we still need to know regarding infectious aerosol transmission, COVID-19, but also all other infectious diseases? And Bill, we'll start with you.
Okay. Wow, that's a big question. We talked about this a little bit in the previous session, but I'll bring it up again because I get this constantly. It would be really, really, really nice if we had some way of collecting a virus and saying, yeah, it's infectious, or no, it's not infectious, without having to take it back to the lab and culture it. Because that's, for all kinds of reasons, that really complicates things. But the problem is, I do, most of the aerosol sampling I do PCR, an analysis. And usually when I do that, the first thing I get from the physicians and the epidemiologists is, well, yeah, but how do you know it's infectious? If you don't know it's infectious, you're not telling us anything. So yeah, that would be the one big thing I would point out. It'd be really nice to have some way to do that without actually having to do culture.
I think I would really like to know what size of particles are mediate transmission, or how efficient is transmission at different size particles, or how much does it, because that would really tell us something about mitigation. And there's some clues out there, and obviously it seems right now, obviously, all sizes seem to be in play, but it would be nice if we knew, the majority of transmission involves particles between this size range, or something like that.
There are so many interesting questions. It's really hard to decide. And sometimes I read old papers. Lindsey and I were sharing some old papers from the 30s and 40s, and you look back at and if any of you have ever read Riley and O'Grady, 1961, Airborne Transmission, Richard Riley summarized everything that was known in a nice little book that's only about 170 pages long. And we hardly know anything more than what they did. In fact, we forgot most of what they knew. That's the big problem. And the other part is that Riley, even though he was president of the American Thoracic Association, so he was an MD, and he really was one of the people, along with Settle Mills and Wells, that did the experiments that showed that TB was airborne and convinced everybody. The problem is that they didn't convince everybody in the infection control community that other respiratory viruses are largely transmitted by aerosols. So I think the missing link is really getting outside of pulmonary and occupational medicine, the rest of the medical profession, and especially the infection control community, to come along. So the thing we don't know is, how do we convince them?
I was preparing or writing an answer which was along the lines of what Linsey said, and in terms of the size-dependent viral load. I think in particular that still seems to be something that we struggle to measure, and I think there are very good reasons for that, and we might touch on those later in this session. I think the other thing which has really come up time and time again in a lot of the meetings I've been in is dose. I don't think we know what the required dose. Well, it takes some time to really work out what the required dose is to become infected.
Okay, so maybe to drill down a little bit more on what we do and don't know, as far as the changes in aerosol infectivity of SARS-CoV-2 once it's exhaled into the environment as an aerosol, what are the key things that you think that we do know, and the key things that you think we still do not know?
Linsey, you've looked at that. Why don't you?
I was involved in a paper looking at the virus survival as a function of humidity and temperature, but I hesitate to apply those to the real world because it was in culture medium, and we've done so many studies showing how important the composition of that medium is. Typically, I would say almost all the papers on virus survival in droplets on surfaces or suspended in aerosols involve the virus in culture medium. And so we get a certain pattern of survival, but we've gone and done this. As soon as we add kind of physiologically realistic medium, like kind of the material that's from human bronchial epithelial cells grown in culture, but kind of like some of the stuff you wash off them, what they exude, completely changes everything. And so I thought I knew what was going on, but now I know that I don't know what's going on.
I'd perhaps like to just kind of follow that up, because I think, okay, so I'm a little newer to this area than Linsey, but it does seem to me that there are some things that we do know. So I think we do know that the phase of the particle is important. Phase change plays a role. I think we know, I'm pretty convinced that we know, and from work we've done, work Linsey has done, that pH is actually important. And so I think there are some cause factors which really can be, it may be difficult to predict what they are in real human secretions. It may be very different from a model system. But I think we can use the model systems to really establish what the course drivers are for changes in infectivity. And I think it's then about how you translate that to understanding, for composition of real secretions, how you map that lab study onto real aerosol. So I think there are some things we do know. It's just about how we translate them. I think what I would like to see, and I think we need to do, is to really, in those lab studies, bridge that gap between model systems and real world systems, and really try to move towards making measurements on sampled respiratory, sampled saliva secretions that really actually, from a biobank that we've sampled from individuals. And I guess traditionally that's not been done because there's been such a focus on airborne survival from a biological warfare perspective, and the use of Goldberg drums and looking at long time scales. And so I guess that's where we perhaps have to shift our mindset in terms of really understanding human respiratory secretions and the dynamics, and translating our lab studies into that context.
I think one of the interesting questions to me, coming at it from a more medical point of view than an aerosol scientist, I'm not an aerosol scientist, I'm a physician, is this phenomenon of anisotropic infection, where we see with influenza that nasal inoculation of the virus causes a very mild syndrome, basically a head cold. And it requires doses of about 10 to the 5 to 10 to the 7th TCID50s. Whereas less than 1 TCID50 delivered by aerosol causes influenza-like illness with fever and chest tightness and cough. And we don't know anything about whether that applies to coronaviruses or much about any other viruses. It's really because of experiments done in the 40s and in the 60s in what we would now consider totally unethical studies on orphans and prisoners that we know this. But we need to know this, not just about influenza, but about SARS-CoV-2 and about other potentially airborne infections.
So I'm going to switch topics for a minute. There has been a lot of talk about preventing indoor transmission using HVAC and other means that are quite energy consuming. At the same time, we are seeing unprecedented weather events related to climate change. So how do we as a community develop technologies that are actually sustainable while pushing an indoor clean air agenda? What types of technologies need to be developed? And how do we sort of, because we're a very climate-focused community, also manage the new aspect of our community, which is preventing indoor transmission by aerosols?
Yeah, go ahead.
I don't have anything on ideas or thoughts on the technologies, but I do think we need to work with architects more. There seems to be, we collaborate with other engineers and scientists, but for whatever reason, it seems like there's very little collaboration with architects. And they are advancing building designs that make better use of natural ventilation and energy saving ways of moving air through buildings that are really innovative and really neat that I think we would gain a lot. I think you would gain a lot if you build collaborations with architects.
Okay. I guess the first thing is be aware of the problem. Make sure you're considering that when you're thinking about what you're doing, in terms of recommendations you're making for HVAC. The other thing is, there was a really great plenary session this morning talking about filters. I hope everybody was there because it was really good. But one of the things that Dr. Siegel mentioned was, look, he said, the fact that you've got a better filter doesn't mean it consumes more energy. Doesn't mean necessarily it has to have a high pressure drop. It just means, you need to change the designs. You have more pleats, deeper pleats, things like that. And so I think that's going to be true for a lot of the stuff. I think if you do it intelligently, and if you're careful, and again, if you just be aware of the problem, there's ways you can reduce indoor transmission, but still, hopefully not increase or maybe even reduce energy consumption, that type of thing.
A lot of my interest in UV air disinfection or germicidal UV has been with the idea that you may be able to achieve very high rates of effective clean air delivery from the point of view of infectious agents relative to the amount of energy input. But it may be that by optimizing filter technologies you can do as nearly as well or better from some points of view, because you're also going to be able to remove other contaminants. But I think we need to put a lot of energy into each of these different options that don't necessarily require bringing in outdoor air. If we can make the International Space Station and the next generation air breathable, maybe we need to be thinking about our buildings in similar ways.
Actually, just to hop in and pull the thread on that more, and I don't know anything about HVAC consumption versus lamp like UV lamp consumption, but do you have any more information on like how much energy each one pulls? Because to me, it seems like there's an energy sink for both of those.
That's something that I'm very much interested in and trying to learn more about, but I don't have any numbers. My assumption has been because you can get to hundreds of equivalent air changes per hour with UV that it would have to be more energy efficient. On the other hand, the upfront investment right now to put it in is pretty high, and I heard from Kath Noakes when I was visiting her lab last week that in fact in British schools they're finding that they can get more efficient cleaning and they're less power with the HEPA filters. So I was very surprised. I want to understand that better because I don't see how with HEPA filters you can get to 50 air changes an hour. You can do that with UV. But the question is, where do you need to get to? And that's another big question.
So I think I was going to respond to this by starting off and saying I'm a lab scientist and I really value rigorous lab work. I think one of the things I have learned is that as soon as you start dealing with infectious disease transmission on a population scale, to really convince policymakers, to convince changes in how we implement control measures, what you really need are randomized control trials. And I think that's really what, as a community, maybe is a challenge to us. And I think that this picks up on what Donna's just mentioned about some of the work that Kath is doing, because I think you really need those large studies to really work out which mitigations really have the value. And we might prove something works in the lab, but we really need to up the bar, just as you would with any other medical intervention. If you're going to any new drug, any new clinical treatment. I think having said that, I would say that I think there are perhaps some interesting things we could do. So if pH is important, for example, and I'm probably going to say this because we published a paper on it, I think the fact that exhaled aerosol goes quite basic, what brings it back down is condensable acids in the atmosphere. So if you're looking for potentially a new control technology, if you could remove those buffering acidic condensable vapors, that might just keep the pH high enough for long enough that actually you could you could potentially reduce your infectious exposure.
Thank you. So I'm going to switch over to Slido real quick, and this question was actually asked in the last session, but I'll maybe put a twist on it for this session to address gaps. So the question was, to what extent do you believe that research in the aerosol field prevented COVID-19 related infection and deaths? Any particularly impactful papers? I'll add on, if there were any impactful papers, how do you think we could do that better and more quickly in a future pandemic?
Okay, I'll start. It's obviously there's been lots and lots and lots and lots of publications over the course of the pandemic. I would argue probably some of the most impactful papers is there's been just a series of kind of reviews and commentaries by Linsey and a lot of other folks that were just pushing the idea of, hey, look, this thing is airborne, this thing is an aerosol transmission. And especially early on when there was a lot of resistance to that idea, I think that a lot of the reviews, the commentaries and stuff that was public done, I mean, you were on a lot of those too, I think that probably had more of an impact on policy and that type of thing than any other particular paper I could think of.
I think Bill Lindsley's work was out of his lab was really important for convincing people that masks could, in fact, work, because I think there was a lot of messaging early on that masks would be useless or potentially even harmful. And his lab produced a series of studies showing that, even cloth masks and gaiters, do something. It helped buttress the argument that any mask is better than no mask, and that you can take a surgical mask, which cost a few cents, and really, through some modifications, turn it into a really effective piece of protection. I think that changed the discussion about, helped change the discussion about masks.
Yeah, another paper that had a big impact on masks was Nancy Lung's paper in Nature Medicine in early April, which, I mean, I have to admit that I had held up publishing that paper for several years because I have some issues with some of the methods in it, even though it used my, the device I helped develop. But that paper at the time that it came out was so timely, coming out in April and showing that surgical masks reduce the shedding of coronavirus, seasonal coronaviruses in air. And the preprint for it had been cited a couple days earlier by Harvey Feinberg in his letter to the White House, which had resulted in the White House calling me up to talk about surgical masks. So like that paper right then, I think had a huge impact. And even though I don't think it's my best one of the best papers I'm on, it's been was downloaded in the first 9 months 2.1 million times, and is now, I understand, about in the top 25 ultrametric scores of all time, or something like that. So, timing is everything, But that had a huge impact, and here we are wearing masks, and that built a lot of other stuff built on that. We had already published a paper years earlier showing that masks work for in 2018 and early in 2013. Yeah, I'm sorry. And I remember, showing that masks reduced flu virus in the air. So the idea, and I think Linsey was pointing out that Wells had a paper in the 30s about that he mentioned with masks as an intervention. So the idea has been around, and of course we know it was used in 1918. How do we stop from going backsliding after if they knew about it in 1918 and 1930, why didn't we know about it in 2020?
Yeah, I think that was very much what I was going to pick up on, and I think this is a recurring theme, that actually, how well do we all know the literature and actually get the messages across that need to be conveyed based on prior work. And I think, in the UK, early on in the pandemic, and I guess this was partly because of the uncertainty around airborne transmission, but the message was very clearly space, face, hands. And I think Katherine Oakes continued to point out, and persist in pointing out that actually really needed to be a fourth word there, and that was ventilation. And eventually, the position changed and ventilation was adopted. And at that point, I think people were a little confused, because the messaging had changed, and ventilation is perhaps not as easy a word to understand as hands, space, and face. And I just wonder, certainly in the UK, if that fourth word had been there from the very beginning, what difference that might have made.
Thank you. So we have another question. Actually, we have several questions. I think recently it was declared that the pandemic is over in the United States. And then we had several other questions about funding, and obviously the people in the community have enjoyed a surge of funding that probably wasn't previously there. And I think for some context, in 2003 we had SARS, in 2009 we had H1N1, then we had MERS, we had Ebola. None of this is new. Obviously nothing had the same global impact that COVID-19 had. But a lot of the questions here are asking, how do we make sure there's continued funding, and how do we engage on that? And I think that fits perfectly in a gap, because we're not going to be able to address any gap unless there's the funding there to do it. So, any thoughts on how to help ensure that there's continued funding in this area?
Well, that's a tough one. I don't work in the funding end of the operation. You're right, it's an important question. I don't think I have a really good answer to that, unfortunately. It's how do you keep people's attention focused on something? Once the problem has kind of gone away, the money tends to go away too.
I wish I could say otherwise, but that's what I see happening. And the pandemic, I would agree that like the emergency phase of the pandemic is over, but we are going to be living with this for many more years, I think. I have described it as, well, we're stuck in this loop of so many people get it, then we get new variants, and then, it evades immunity, and this is going to keep going for a while.
Yeah, the University of Maryland student newspaper FOIA'd the campus information about COVID a couple of weeks ago, and is now publishing papers showing that so far this semester, as of early October, we've already had more cases on campus than we had in the entire fall of 2021, or the spring of 2022. So that, but the campus it's over. We don't use masks anymore, and the administration has turned down my offer to build Corsi Rosenthal boxes and put them in all of the cafeterias. So I don't think there's a solution to this problem. I think this is a very human characteristic. We respond to emergencies, and then it's the next thing. And we want to forget. We want to actively forget what it was like. And I saw some article, probably in Atlantic or something, pointing out that when you look at what happened in 1918, and then you look at the literature and the culture in the following years, there weren't a lot of books or plays or anything that talked about the experience of the 1918 pandemic. And I find this, in my spouse's family, they immigrated from Europe in the early 20th century. To get them to talk about where they came from, their attitude was, no, we don't want to talk about the bad old days. So I think there's a very human, we want to just forget and go on with our lives. And we're just going to have to deal with that. That's the way it is. Right now, you've got a bolus of money, do good stuff, and hope that that in 25 years we haven't reduced the ventilation rate back down to 5 CFM in order to control just body odor.
I'm going to perhaps provide a view from the other side of the Atlantic in terms of where I feel things are at in the UK. And I think I can remember the 80s just about, well, I can't remember the 80s. And I know that actually there was a lot of, aerobiology, there was a lot of work in aerobiology in the 50s, 60s, 70s. And actually that was because of, the threat, biological warfare. And a lot of that expertise has really been lost. And so certainly in the UK, we really struggled early in the pandemic because actually there weren't really people with the knowledge and the skills required to even provide advice and guidance to government in this area. And I think that has changed, it is changing, and it takes some time to build that expertise. I think we have a much better network in the UK, much more agile network of multidisciplinary teams, people working in very different areas that can really contribute to this. And I think that's been a real gain for science in the UK. We have got some national core study funding in the UK that unfortunately is being wound down by the government, very similar to here. But I think there is a real willingness across, from the medics through to the engineers, through to the physical scientists and the life scientists to really collaborate and work on these problems. And the trouble is they nearly always fall at the boundaries, certainly in the UK, the boundaries between research councils. And so actually identifying sources of funding has always been a problem in this area. So I'm not sure I necessarily have a much more positive answer in terms of where the funding is going to come from. But I think the argument is much more clearly being made, and I think there is now, certainly in the UK, I'm sure it's true in a lot of places, real critical mass and a real willingness to work together in ways which haven't been there in the past.
Okay, we're going to circle back a little bit more on the aerosol and more technical side of things. One of the questions that we had was, how do we think, there's a lot of push in UV technologies for mitigation. How much do we actually understand about the effectiveness of UV technologies with respect to the actual composition of respiratory aerosols versus sort of the studies that are done in a laboratory using something like tissue culture media and a more pristine sort of particle? And how do we think that, what kind of studies do we need to do to really understand the complexity of that and truly get to how much UV inactivation is going to be required to be effective? Or if you think we understand that, please then go ahead and elaborate.
Well, I think the best data we have are from the human to guinea pig TB studies, the one done in Baltimore in the 1950s, and then the one in Peru and the one in South Africa. And what they showed was that with something like 12 milliwatts per cubic meter based on the volume of a space, but confined to the upper room, that they were able to achieve an 80% reduction of transmission to guinea pigs. So, and all three studies are quite consistent in that. And so, we know a whole lot less about finding the new technologies and whether they can do anything, whether you can get enough dose in to do things that would interfere with short-range aerosol transmission. And so that's a huge question. And how well it'll work for viral aerosols, it ought to work better because TB should be, from the laboratory data, much more resistant. What is the optimal way to design these systems? To what extent do you need good air mixing? The laboratory studies certainly suggest that you're going to get 5 or 10 times more clean air delivery, effective clean air delivery using a ceiling fan with an upper room UV system. But many of the vendors will claim, well, there's enough convection from people and ventilation systems and so forth that you don't need that. But so I think we need some kinds of real-world studies that can get at that, and they'll probably be, and we need some more efficacy studies of actually looking at field studies of how much can we reduce transmission in an environment. But the other side, when you get to field studies about airborne infection, you really have to think carefully about what it is you can accomplish, because that's the apocryphal case of where the Welleses did these studies in the elementary schools in Germantown and Swarthmore and really suppressed measles in the classrooms that they put it into. But then when it was done in upstate New York, the attack rate over the course of the semester was ultimately the same. But what they did is they flattened the curve. They didn't have a rapid epidemic. They had a long, smoldering one because the kids were all riding school buses for an hour. And I understand that, which I haven't read, but there's another study from, according to Riley's 61 book, done in London, in post-war London, when people were living in crowded conditions, where kids were getting infected, living in walk-up apartment buildings and so forth. So that, what can you really accomplish even if you put UV in all of the public spaces in a town, as Mildred Wells did in 1948 in Pleasantville, New York? What can you accomplish? And I think there's a lot we have to think about in that context.
Any other comments, or on to the next question? Okay. So we have another question from Slido. So obviously COVID was bad, but when we look at things like Ebola with a much higher mortality rate, it could be worse. So the question is, in the case of an outbreak of an acutely lethal agent such as Ebola, how would you want the pandemic response to differ from that of COVID?
I want to have a lot of different disciplines at the table thinking about what to do, rather than just traditional infection control people.
I would strongly agree with that, and I also think that individuals' response would be different if we faced a pathogen with a 10% mortality rate rather than a 1% mortality rate. And so I think, people, if it were some kind of respiratory pathogen, I'll bet you more people would be masking.
Yeah.
So I'm going to ask a controversial question, and this is really your opinions. But when do you think it's sufficient for us to stop masking, considering that SARS-CoV-2, COVID-19, it's endemic, it's like flu. We're going to deal with it now and for the rest of our lives. What is sufficient, in your opinion, to be comfortable with messaging specifically out of our community that we do not need to mask in public spaces?
I'll give you a very broad answer to that question. Here's the thing about masking. We can do lab experiments. We can show like how much a mask blocks aerosols. We could, based on other data, we can make a pretty good estimate even of how many infections you might prevent with that. On the other hand, you can also look and say, look, there's a cost to masking. It makes it hard to communicate. It's uncomfortable. It makes it harder for kids to learn in school. So there's a trade-off there. And the question of whether that cost is worth that benefit, that's not a science question. That's really a question of what your values are, what your priorities are as a society. There's a trade-off there you have to make. And that's not something, that I can answer in a lab. That's something we all just have to get together and decide.
Yeah, I would strongly agree with that. In the public science communication work symposium panel that we had on Monday, I pointed out that, I think we are well qualified to provide scientific advice of, okay, how well do these masks work under certain types of conditions, but the policy questions, that's not something, there are people who study policy and who have expertise in policy, and they will weigh science, they'll weigh economic, social, and other considerations. And so I personally don't think that it is our duty or responsibility, or that we even should weigh in on those things. I think maybe we can, from a personal point of view, but as a scientist, no. And this is where I think that some things have gone wrong in the climate discussion, in that, it makes, if scientists start weighing in on policy, then somehow it seems like the policymakers then come and twist the science to fit their narrative. So I think we would have better trust, maybe, if we stay with the science and say, okay, what I always like to say when I'm asked that question is, I've gotten asked by reporters, well, should we have universal masking? And I say, what, that's really a policy question. But I would say, if we choose to have universal masking, then here's what the science tells us about the effect that would have.
I'll perhaps give maybe a little bit of a personal reflection on this in terms of, I've always felt as a scientist much happier being in the position of trying to be an honesty broker rather than a campaigner, and giving the best advice I can, the most objective advice I can. I know that particularly on the issue of climate change, there are some scientists who are now saying that we tried that and actually there is no room for that, and actually we now need to become campaigners, and you see that very evidently on the climate change debate. But I think I would agree with Linsey that actually at some level then you sacrifice your right to express some independence of policy and to actually make some and to give fair and well considered scientific advice. I think there are real challenges in terms of perception of risk. We all know that as individuals our perception of risk and how we think about risk, it's very much an individual thing. We all respond in very different ways, and you can't legislate for that, and I don't think you should try.
Coming from a public school of public health and a public health perspective, there's recently been some discussion in the public health literature about whether the public health by trying to become more scientific and give advice and not push for policy gave up its power, that public health by being advocates got workers' compensation, got sewers and clean water, and that now by being very respectful scientists we don't accomplish very much at all. And so I think that there's roles, there's a lot of different roles. And you need people with a lot of technical expertise and passion to push for the things that need to happen. Those may not be the same people who do the hardcore laboratory research, but there are issues like environmental justice issues that you are not going to get anywhere on those issues if you don't go at it as an advocate with a lot of passion. And you need to come at it more like a community organizer or a labor organizer. And so there's different roles for different people, and you kind of have to find what is the place that you fit and what can you do, and where are you comfortable. I mean, I kind of fall in between those. I feel like I do some amount of advocacy, but mostly I try to just make measurements and tell people what I find. One of the things that my mentor in medical school was a guy named Ted Radford, who was chair of the Biological Effects of Ionizing Radiation Committee. And his contribution, his committee came up with the low dose zero, the linear extrapolation, which was so controversial that the National Academy repealed it with the next committee and then reinstituted it with the one after that. And Ted told me, he said, I know I'm on the right path because the industry hacks all hate me and all of the anti-nuke crazies hate me too.
I want to add one thing, which is that I think Don brought up a good point, which is that there's different roles for different people. It depends on who you are, and that I have really tried to be very careful because I am a woman in science and engineering. I am not white, and so I feel that I am subject to an extra level of scrutiny. And so I have tried to be very, very careful about what I say, because I know that people it'll take almost nothing for people to attack what I say or attack me due to my gender and race. And I think that's, different people have different experiences, and that's just something that factors into my role.
Okay, so oftentimes the government uses what we call tabletop exercises to work through scenarios on how we would respond to an emerging pandemic or a biological event. So a new respiratory virus surfaces in a school in the US. What is the first thing in your mind that you want to know or that triggers you to think we need to implement some type of mitigation for aerosols? What are the things that are indicators to you? And you could think about it in the context of COVID. What was the first time you thought, this isn't like SARS-1, this might be different?
Well, I mean, that last part of the question I can answer very easily. When I saw the first paper coming out of Wuhan, in which they had a 10-year-old who was asymptomatic and had ground glass appearance on the CT scan, I said that means there's small airway involvement. And there's airway collapse and reopening, and that's going to generate aerosols, and that's going to make it very likely to have an airborne component. So, I mean, that's an answer to that very specific part of the question. I'm still thinking about the rest of it.
I'd probably look at hospitalization and mortality numbers to see, how seriously do we need to take this? Because you don't want to, every time a new pathogen emerges, you don't want everyone to go on high alert, because I think you'll just numb everyone. And there's a cost to that too.
Also, you'd like to do contact tracing, to kind of try to get a sense of how the disease is going from person to person just by, do these people, do they share a household together? Are they very close? Or is it just somebody who, sits across the classroom, somebody doesn't have any other interactions, that type of thing?
Yeah, I think, like, as Linsey said, a precautionary principle should or can be used, but again, that has to be balanced. And yeah.
It seems to me, though, that what we need to accomplish is that we have all of our schools have good air hygiene, whatever that means in terms of ventilation, filtration, air disinfection, so that our public spaces, and especially our schools, are resistant to the transmission of respiratory viruses, so that we're not freaking out when we figure out that that's what's going on. And that we, and as in the experiment where they put upper room UV into a school in upstate New York, and it didn't prevent measles transmission, but it flattened the curve. And it gives that, and you remember back in the spring of 2020, we were talking about flattening the curve, and Harvey Feinberg then was head of the Institute of Medicine, talked about crushing the curve. But we need to have environments that don't make this permissible. And that's hard. And especially, I think about conferences I've been at recently that turned into super spreader events, and most of the event was okay. I think it was the bars that people went to, and there was the conference party where people were dancing close together and yelling, screaming along with the band, and like, I don't know what you can do about that.
So I'm going to kind of go back to the multidisciplinary aspect and bring up something that was brought up last night at the bioaerosol working group meeting about the inclusion of people who are from the agricultural field, veterinarians, and kind of when we're talking about like pandemics, if we're talking about filters, masks, and UV, like we're really too late, right? Like if we can stop things at the zoonosis point, that would be much more effective. So I thought the suggestion of veterinarians in the agricultural field is really important. So I'm just curious, any thoughts on any additional fields that we can try to better engage, and ways we can start to attack the problem further left of boom from the kind of biodefense world.
I had a great conversation with a nurse at Emory University who works on the special isolation unit ward, and who handled the Ebola patient who came to the U.S., and she had a ton of great ideas, and I had not talked with a nurse before, and she really values our research because of the type of environment she works in, and just it was really eye-opening to me. So I think talking with people who are actually, working, like that is their job and it relies on knowledge of aerosol science, I think could be really helpful. And also we ran a National Academies workshop last week, and it was really enlightening to hear from someone who worked in facilities at a school, and just kind of the barriers that they face, so that we have a better understanding of what's, what we can do to be most helpful.
I'd like to respond to that a little bit by thinking about how we train aerosol scientists, because I think, yes, perhaps we don't always consider ourselves first and foremost an aerosol scientist. We all have potentially a home discipline that we come to aerosol science through. And I think it's really important for us as a community that we look at how we train the next generation of researchers and think more about how we build interdisciplinarity into their training. And, we have an example in the UK where we're trying to do that, and it's really exciting to see the students working together in very multidisciplinary teams and learning the language of the other discipline. And I think unless we do that, actually, we're setting ourselves up for a fall again, because we need those communication skills, and you can learn those on the fly, but it's jolly hard. Sorry, English expression. I think really we need to be building those into how we train postgraduate students, PhD students.
Yeah, thinking specifically about, you were talking about zoonotic transmission. There's a program called One Health that's, a lot of you probably heard of it, but CDC is involved, a lot of universities are involved. That's a lot of what they're doing, is they're looking at, animal to human transmission, they're looking at, monitoring health status, viruses and things in different animal species and that type of thing, and kind of looking at the, not just human health as something separate, but as part of a bigger ecosystem.
So I think we're basically done. There is one question out there. So to end on a positive note, somebody asked, do you have any suggestions for an early career researcher or faculty on how to contribute to health-related aerosol issues? How do you get into this field? And I think because we have you, some of the most respected members of this community who have contributed so importantly in the last few years to this particular problem, what would be your guidance to them if they want to get into this field? How to start? What they should tackle?
Find a good collaborator, number one, and then be willing to face a bit of rejection along the way.
First thing is to do it, certainly. I think what Linsey said, find good collaborators, find a lab, an organization, that's working on this kind of stuff. By all means, look for university positions, things like that, but also keep in mind there's organizations like NIOSH, like National Institutes of Health, other groups that also do this type of research. And so, you can kind of broaden your possibilities out a bit.
I would say really be prepared to work at boundaries. I think that's really what I guess we all do as aerosol scientists, but you really need, I think if you look for those boundaries between disciplines, that's where a lot of the advances happen, actually. And it's not always recognized, and it's certainly not always recognized by funders. But actually, go and talk to someone who's not in your discipline. Try and learn their language.
I agree with all these things because I think for me it's collaboration with engineers, with real aerosol scientists, since I'm not one, and it's get a thick skin, because I've been called names in some of my rejected papers, especially if you go back 20 years ago when I was submitting papers about smallpox, which then there was all this concern after 9/11 about, was the Iraqis have it, and so forth. And I wrote this review article that gotten a little bit of attention recently. But I got some, especially from emerging infectious diseases. The reviewers at the CDC were ruthless. So you gotta okay, and just keep rolling with it. You'll get there.
All right. Well, thank you all for your great insight. I think covered a lot of really important topics, and also I want to thank the first panel, everybody that asked questions, as well as Shanna and Alex for organizing this, and thanks for everybody for attending.